Okay, good afternoon. I'm Masuma Mandani, and I'm a public health professional working in the larger subject area of universal health systems, with particular attention to practical policy analysis and change, processes in support of change. And together with my three dynamic colleagues that you see on screen, a brilliant team of SDH advocates, we welcome you to our session on social determinants of health. Basically, exploring what are these determinants, their conceptual framing, the multiple deprivations impacting on our health and well-being, especially of the most vulnerable and marginalized populations, and the importance of driving an intersectoral approach to addressing inequities. And how do we really collectively move forward given current challenges nationally, globally, and regionally? How do we move forward? So we're absolutely thrilled to have you with us. And I'm actually now going to hand over to the chair, David, and my colleagues to introduce themselves. David.
Thank you, Masuma. Welcome to everyone. So my name is Davide Ziveri, PhD in social psychology, working in the Global Health Unit of Humanity and Inclusion, the new name of Handicap International, based in Brussels. That's why this blue light on me. Sorry for the quality of the video. And yeah, great really to meet you and to participate in this meeting. Thanks for having me here. I let the floor to Sandrine.
Yeah, thanks, Davide, and happy to be with you this afternoon, even though it's a pity not to see you, but I'm sure we will interact with questions. So my name is Sandrine Simon. I'm the head of the Health Advocacy Department at Médecins du Monde, Doctors of the World, France, and happy to discuss this afternoon with you. I pass the word to Renu.
Looks like we're facing some technical Renu is back. Great.
So hi, my name is Renu Khanna and I'm from India. So good evening to all of you. It's 6:30 over here in the evening.
Oh.
And I belong to a community-based organization called SEHEJ, or Society for Health Alternatives. And I've been working on gender rights and health from a social determinants perspective and also from social accountability within the framework of social accountability. So I'll be talking about my experiences here from these frameworks.
Thank you. So I will just kick off with a brief introduction on health and the social determinants of health. And what are they? We all know there are conditions under which people are born, grow, live, work, and age. But there are also the deeper factors in past and current political economies. And we're just going to use the 10 minutes to go through two frameworks to help us understand how these determinants interact with each other across many levels and the complex interactions they engage with to influence and impact on our health and well-being. There is a link in the chat show. You may choose to click on it because for me it's always easier to explain having the framework in front of me. So I'm actually going to click on that right now. And the first framework is by Dalgrain and Whitehead framework, which takes a multi-sectorial approach. There's all these concentric circles, and the core is which is the inherited attributes relating to age, sex, and hereditary factors that impact on our well-being. We have the second and third layer. The second layer where health is partly determined by individual lifestyle factors such as patterns of smoking, drinking, physical activity in diet, everything actually that we're currently experiencing with increase in diabetes and other chronic diseases. The third layer draws attention to relationships with family, friends, and other social networks within the local community. Social cohesion and social capital are factors that bridge the structural and the intermediate determinants, mutualism, support structures, the willingness of people to living in community to make sacrifices and to cooperate with each other for wider benefit. And we see the fourth layer, which really pretty much illustrates the working and living conditions, housing, employment, education, water, sanitation, access to healthcare, all of that. And that kind of influences and shapes a person's position and place in society, which in turn impacts on exposure and vulnerability to conditions and plays a role in determining health outcomes. The ability to feed and clothe oneself, be gainfully employed, quality of housing, all of that. We have the final layer, the broader socioeconomic, cultural, and environmental forces. And these refer to the socio-economic and political context in which a person is born, lives in, and born into and lives in. And it's linked to governance and decision-making processes, how society organizes itself and implements decision, how inclusive are these decision-making processes. So, for example, income and education and impact on health and poor health can limit opportunities for people to participate in the workforce or receive education, which in turn affects earnings and livelihoods and so on. It's a vicious circle. And if a population is affected by a higher burden of disease, it has a broader negative impact on socioeconomic and political context. We can take another quick example in terms of the implications of increasing urbanization and the growth of informal settlements, and how does this impact on well-being of those working and living in the informal economy. Unplanned urbanization, informality, insecure residential status, there are many urban households excluded from essential public services. Environmental and health hazards are major contributors to illness and death. And unemployment, and especially in urban areas with irregular incomes, people who live in precarious conditions are deprived of the most essential rights and entitlements. And this is also particularly true for younger people when you see them working in conditions, substandard working conditions. And we notice more and more the increasing numbers suffering from mental disorders, depression, and engaging in alcohol and drug substance abuse. Moving on to the next framework, which kind of actually is the first framework that brings on board the global forces. And this is what I call kind of the framework that was modified by the People's Health Movement. And when you look at this, you see the framework's divided into the upstream, midstream, and the downstream factors. And the upstream factors are the global and national policies, the general socioeconomic, cultural, environmental conditions, the living and working conditions which have the biggest influence, close to 3/4, on health and well-being of communities. And then we have the midstream factors, which is a mix of living and working conditions and social and community networks and individual lifestyles. And then the downstream factors that include psychological and biological causes of diseases. So together, the midstream and downstream account for roughly 30% of how healthy an individual or community is. For example, a good health system will help cure your substance, but it's not going to address the causes behind the causes, those linked to poor living and working conditions. We live in a globalized world. We're not isolated. We're impacted by global policies, their actions, or rather their inaction. We rely on global policy for equity in resource distribution, for equity in social justice, a healthy environment to live and work in for all, what we call the common goods. At the moment, the biggest vaccination campaign in history is underway, the COVID-19 vaccines. So how have these global inequities in distribution of COVID-19 vaccines impacted on our lives? How do we address these growing inequalities? What sort of alliances do we need to forge? COVID-19 has exposed inequalities, but it can also be a catalyst for necessary change. So to kind of conclude in this very quick, brief presentation, social determinants of health, as we see from these two frameworks, they're driven by inequalities in the distribution of money, power, and resources at all levels, at international, regional, national, and local. The pockets of inequities at every level. And it's important to address these determinants, not only to address inequities, but really as a matter of social justice, to set right the significant inequities between and within countries, a symptom of larger fabric of society. And addressing these inequities, as we see from these frameworks, really requires actions across all sectors of society and all levels. And the actions will depend very much on existing socioeconomic and political context. There's no blueprint, resources that are available, and most important, the commitment for action. At this stage, I'm actually going to stop and hand over to David for the ongoing session, and then we'll come back with some more questions. David, over to you.
Thank you, Masuma. Thank you. Because, you help us in navigating in this complexity. And that's why I guess that today we are not going to find one solution, because there is no one solution fits all facing that complexity. So the idea now is really sharing experience, starting from what we are already doing as humanitarian actors on the field, what we saw during the ongoing pandemic. And just to break the ice, I can start in behalf of Humanitarian Inclusion, keep it in less than 5 minutes, because I'm really keen to listen from my colleagues here on the panel. So my starting point is that we know, because we listen again and again, that no one is safe until everyone is safe. So the question is, what about the 1 billion people with disabilities worldwide? So 15% of the global population, 80% living in low and middle income countries. During what has been defined as a pandemic, where social problems, so the social determinants of health you mentioned, are clustered and interact continuously with health emergencies and the medical problems. And the experience of living with disability during a pandemic is also shaped by intersectionality with other aspects like gender, age, migrant status, etc. So if we look at some of the situations created in those intersections, we see, for example, that sometimes the COVID-19, or better say, the response to prevent and control the pandemic, has put even survival at risk. Here some data. Almost 1/3 of the respondents to COVID-19 disability rights monitor survey in 81 countries say that last year, during the first phase of the pandemic, people with disability could not access food, for example. And in terms of protection, a more recent survey in Syria found that households with members with disabilities are more likely to experience family separation. That in turn undermine household security and, of course, access to income. And when we have lower income generation, of course, we have an impact at many levels, for example, on well-being. And actually, it has been found from an IDA survey among people with disability that there is a statistical strong correlation between the loss of income and being and feeling more anxious. That is not surprising, but we have to consider all those aspects at the same time. And when we speak about financial insecurity, for example, we can think how these affect the access to education. And it has been very clearly reported, for example, by the World Bank survey on inclusive education. And distance learning has not really been a solution for everyone. That's the problem, because the social determinants of health, among them, for example, simply the access to energy, the lack of electricity, or access to devices and digital literacy gap for many children. And when coming to children with disability, UNESCO denounced that very few schools have tried to adopt the inclusive methods and accessible digital learning environment adjusted to the needs of learners with disabilities. So when we speak about social determinants of health, we are not speaking, in my understanding, about simple blocks, because it's really the experience of each person and each community living in that condition. And before ending, I also want to mention the inclusive health. That is another social determinants of health. First of all, the access to information that during the pandemic, of course, is crucial. And but what we found, for example, last year in Ethiopia, just to give a snapshot, is that 10% of surveyed adults with disability had no access to information, and 20% of them found information difficult to understand. That's why I think that some tools like the risk communication and community engagement for vulnerable communities are really welcome, because we need to adapt, of course, information. But then also the access to health is at risk. For example, last year in the same period in Jordan, we found that 88% of persons with a physical impairment and with current medical needs reported that they could not go to the hospital, We know by WHO Pulse report that pandemic disrupted many services, putting continuity of care at risk. And that's why, as HI, we move to telehealth, for example, for integrated rehabilitation and MHPSS services for people with disability and their caregivers. And according to a preliminary internal evaluation in Afghanistan before the current humanitarian crisis, this modality of services has been found effective by the staff and by the user. But I want to be clear, because tackling social determinants of health means going beyond the adaptation of services. That, of course, is important, but it means also to address the root causes of suffering. And I think that the future is not brighter because we have, and you mentioned, Masuma, the challenge of vaccine equity. And for example, just to share another snapshot, our rapid assessment on access to vaccination by persons with disability in Laos just before this summer shows that 47% will not get vaccination due to their disability, and 14% need support for transportation. So tackling all those elements at the same time is, of course, a huge task and not an easy one for sure. And that's why I'm really keen to know more from other panelists how you try to win this challenge too, and sharing experience, we can find maybe some pathway to the future. So I let the floor to Renu first. Thanks.
Did you invite me? I can't hear very well.
Yeah,
Is it
please,
me or Sandrine?
Please go ahead.
Okay.
No,
okay.
Go ahead.
All right. Thank you so much. And I'm going to be using the Dalgrain and Whitehead framework that Masuma described. And I'm going to describe our adolescent girls work, the program that we do. And we work with the urban poor. And so it's a city, its a location is an urban area, not a rural area. But if you look at the larger structural determinants that affect adolescent girls, you see that there's urban poverty, you see that there is precarious living conditions, lack of access to water, sanitation, unrecognized slums, low-lying areas which get flooded, all of these sort of things. Their status as migrants, they have migrated from the rural to the urban areas. There's interstate migration, which means that language is different, the social networks are not there. Political factors like the right-wing conservative government, which has actually banned comprehensive sexuality education in schools in my state, for instance. So all of this actually affect and marginalize young women even further. Adolescents, if you look at the individual factors, the central circle in the Dalgrain and Whitehead framework, it talks about individual factors. Adolescent girls, because of their age and because of their gender, are actually more vulnerable than, for instance, adolescent boys. And added to those factors is the layer of community norms, the gender norms, which create gender inequality, which actually becomes a human rights issue. The right to equality is violated in the most fundamental way. And this leads to discrimination in terms of their right to education, their right to development, to full potential, realizing their full potential, right to nutrition within the home, and all of that. So you see human rights, you see a circle of adolescent rights, the way it's described in the Child Rights Convention. And all of this actually is leading to a violation of their sexual and reproductive health and rights. Early marriages, control over their sexuality, bodily autonomy, lack of mobility, dress codes, as I just said, no sexual and reproductive health information, no body literacy. The first time the girls get their periods is so traumatized because they haven't had any previous information on this phenomenon. No information on contraceptives. A recent study that we did, we found that 6 women in our sample of 14 who were married and had a total of 14 pregnancies, all of them reported that all 14 pregnancies were unplanned. And so you see a combination here of lack of information, and you see gender power relations playing out and resulting in unwanted attitudes to adolescents' reproductive health and sexuality are very, very regressive. They don't believe in giving emergency contraceptive pills easily. They don't believe in, then there are other health system factors like supply chain, no menstrual hygiene products available for the longest time. Iron and folic acid, nutritional supplements not available. So all of this affects girls, so the structural factors, the individual factors, the community factors, all of them are affecting their, adversely, their sexual and reproductive health and rights. And in the COVID period, all of this has gotten further girls don't have digital devices to be able to continue their education. Girls faced a lot of violence within homes, restrictions during the lockdown period, and they were at home. The social networks were all cut off. So there's a lot of depression and anxiety which built up amongst these young women. Menstrual hygiene products were not available for the longest time. Nutritional supplements were not available. The midday meal, school meal that they get, which is a supplementary meal, was not available because the schools were closed down. So all of this, you can see a host of determinants of health at various levels affecting the health of girls in urban localities. Let me stop here. I think I may have taken more time than, yeah. Thank you.
Thank you, Reno. Sandrine, please go ahead.
Yes, thank you. And thanks a lot for already plenty of interesting example. And I completely agree with you that the main, perhaps, point is like social determinants of health are quite complex in a complex context and intersectional, and that's it's difficult to overview all the determinants of an individual and collective situation, and that's perhaps the point that we should.
Is anyone speaking? I can't hear.
Yes. Yes, Reno, I'm speaking. Sorry. So yeah, we have to face with this complex situation, and then we need to take time also to overview those situations, to adapt our project to it. And just to take few examples, because we address already quite a lot. One important, like as a medical NGO, Médecins du Monde, Doctors of the World, we recognize, of course, health is not only about quality of health services, and you were already speaking about that, but it's really about access to health. So access to health, meaning access to services, but also access to good quality of life to preserve your health. And for few examples, perhaps, that we face in our projects, first, we can face sometimes that lack of information for people is key to access health services. It could be lack of access to existence of services, to rights about accessing those services, like services should be free, for instance, but most of people don't know about that. So this information issue is really, really key, and making a lot of barriers for people to access services. It could be also language barriers, like for instance, we work in France with migrants or asylum seekers, and sometimes the language barriers could be an issue to be able to find their way in the pathway of health services that are quite complex, administrative, but also health services themselves. So language barriers could be an issue. And like we advocate since years in France to have health mediators integrated in the health system to make sure people we can address language barrier, but also not only language, but to make sure people understand their way in the complexity of services. So that one point I would like to address. Also, we already speak of poverty, but of course, I think it's a key issue, and with COVID-19, we face it even more in our project. And like, for instance, in our sex workers project, and projects to address the health of sex workers, during this COVID-19, most of the people, they just lose any way to get to have access to financial resources because of lockdown and all the barriers to get resources. And we had to adapt our project to integrate these components also because the main issue for people was not access to health, but was access to financial resources, to get foods, to get whatever they need for fundamental needs for themselves, for their kids, for the family. So we had to adapt our project to integrate also these determinants for them in France and abroad. And just to say also that when we analyze the context, it's always evolving. So we had also to continue adapt ourselves to the evolution of the situation. And when we speak of social determinant of health, of course, it could be moving quite a lot. And perhaps last point I would like to address here, even though there is plenty, it's also the society where people live that can be quite inequitable. I think we already said it, and that can put a lot of barriers, and sometimes laws and regulation deny fundamental access to health for people, and especially for stigmatized, the most marginalized. And for instance, when we speak of drug users, we could see in several contexts that it's not even taken into consideration in the public health approach and in the public health system, that those people could have specific needs in terms of access to health, or even they just need to access health, and stigma and all the barriers put for those people could be a big issue for them. And we face in certain contexts that repression is more preeminent than a public health approach for them. In France, it's the case, but also, and we had a project in Tanzania that address that, and also try to demonstrate to the Ministry of Health the interest also to include key population, and especially drug users, in the public health policies, and make sure they could have access to health services. So we had quite some advances, and we are happy that now the Ministry of Health also integrate this public in their policy. So it's all this component we have to take into consideration, and many more, but it makes our job interesting, but not easy. And just final word on this, just like to address those determinants on this complex context. As MDM, we try to build or to design our project around 3 complementary pillars to try to integrate it. So, of course, integrating quality health services, so making sure health services respond to the need of the person. Also integrating empowerment of people for them to have the capabilities to act for their own health and to claim for their rights if it is needed, and also integrating most of the time an advocacy component to make sure rules and regulation take into consideration the needs of the population as a whole, integrating also those that are most marginalized sometimes. And it will be my final word now, and I get the floor to Davide, I think.
Yeah, thanks. Thanks a lot, Sandrine. It's not the final word because
No,
I really
for
hope
this.
that we have a second roundtable now to go deeper, because what I listened so far is that we have a good analysis of the social determinants of health, because we see on the field the multiple and simultaneous needs of the population we are working with from the disability, gender, and health perspective. But now the question is what we learn from that, what can we do more or better or differently? So you already mentioned, for example, the importance of empowerment. I guess also to give the opportunity to people to work directly on the social determinants of health. But what we as humanitarian community can do, really differently, adopting accepting this complexity and adopting the social determinants of health lens. So I see that we lost the connection with Reno. I guess I hope that it's just for a while. So waiting for her coming back. Mazuma, if you want to say something about that, please, the floor is yours.
Okay. Well, let me just share some experiences from the world of research. So interestingly, the last 15 years or so, I was based in Tanzania, really working with various national research institutions and one of my mandates was to try and develop a portfolio on researching from a social determinants of health angle. Because even within research institutions, they're very compartmentalized in health, so the health systems and biomedical and this and that, and everybody worked in the little isolated cubicles, and partly kind of driven by the funding agendas, where you're kind of accountable more to the financier and you're more accountable to the publication, so your research is not really demand responsive. So the biggest challenge is really how to drive a more interdisciplinary research agenda that would sort of shed light on what are the multiple dimensions of health and well-being. And one of the key messages to tell researchers was that households don't live their lives in compartments. When vulnerability strikes, the first thing that goes maybe is that they stop accessing health services, or the girl gets withdrawn from school, and then 3 meals to 2 meals, etc., etc. So they all impact on each other. And it's been an actually very interesting evaluation and some very fantastic progress in that sort of aspect. Researchers were best known for really providing evidence. And one of, I have to say, the biggest challenges faced was how do you make that research accessible? And of course, there was the challenge to be published before you make it accessible. Which is quite common. But I think one of the strongest channels is to make researchers evidence accessible to those bodies, whether within civil society, they are best placed to drive the activism and work towards changes that need to happen. But more and more, we engage very much at the policy level. And so with the Ministry of Health, our recent engagement over the last few years was very much that they need to drive beyond, they need to work beyond the health sector. And that was really the evidence to shed light on how engaging with the water sector, the sanitation sector, the nutrition sector, working together will impact on health and well-being. But beyond impacting was also kind of linked to the agenda of you need a more coordinated effort, whether at the national level, regional, sub-regional. And so I think there's a lot of work that was like how policies and interventions cannot be confined to the healthcare, but address the systems of health and how you move beyond I mean, the difficulties even within a Ministry of Health, every single body was within their isolated cocoons. It was trying to open those boundaries up as well. I'll hand over to you.
Thank you very much. I like this point, and that is at the base of the health in all policies approach, actually. And so, coming back to health and health system, I let the floor to Sandrine to continue before you stop, please.
Thank you, David. Just a few points. I mean, like, as you say that we understand the complexity of the situation, or what we can do as NGO, as actors on the field, to integrate this in our project. And we think that one important point is really how to better understand the environment where we intervene and their evolution. It seems quite simple to say that, but it's not so easy sometimes when we intervene in acute crisis situation. We are in a humanitarian congress, so I'm sure all of you face this issue, but still we think it's quite important, either in the beginning or at the onset of the project, or continuously in the project, to take time to also understand the environment where we work. So it could be sometimes through research or qualitative diagnosis that try to that integrate also this social determinant of health, and as MDM, we try to do so in several contexts when it's possible. For instance, we did a few years ago some diagnosis about the determinants of unwanted pregnancies in some context in Africa, for instance, to understand really where are the issues. And Renu, you were explaining quite a lot of those determinants a few minutes ago. But also what we found important is to rely on the population expertise. And it's very important for us also to build our project and to adapt our project together with the population. There is drug users in the world that say nothing for us without us. It's something we try to have all the time. It's not so easy also because sometimes we have to intervene quickly and so on, but really try to not destabilize also a situation where people find their ways in a way to address some issue, and it's important for us not to be destabilizing some coping mechanisms that have been put in place by populations. So it's really important to understand this coping mechanism and how we can reinforce them in the community at individual level also. So, for instance, in some projects we work also with peer workers. So people that face themselves the same situation as beneficiaries of our project, for them to be able to share with their peers their experience and how they have deal with this experience also. So could be one example to do so. So it's one point. And other point I already said a little bit previously, but we try in some of our projects to integrate advocacy component to accompany the civil society toward the social changes they want to have for themselves, for their community. Okay, I will keep time. So it's really about also trying to reinforce already existing initiative. In some countries, we have some ambassadors that we try to reinforce in a way that they can by themselves advocate and organizing situation with decision makers for them to address their issue towards the decision maker. It could be only for us to be here to facilitate this dialogue. But it's some example we try to do in some situation. It could be really locally with local health facilities and so on, and it could be more broadly at national level sometimes, depending on the situation, on the context. So really, for us, it's important also to work on health policies and the way they integrate the specific needs of a different group of people. So yeah, I will let the floor now because I think time is short. Davide, it's yours, no?
Thank you. Sorry for a reminder of timing. It's the bad role I have today also. So Kino, Renu, sorry, I saw you join us again. That's great. Welcome back. So we are doing a second round table, trying to go deeper and to focus on what we learn and opportunities from the experience that we share at the beginning. So if you wish to add, please, the floor is yours.
So I can't hear you very well, but I'm guessing that you're asking for sort of solutions or the way forward. And that's what I'm going to be speaking about. So one of the things that, and taking this example of the adolescent girls, one of the other principles which is extremely important for us is participation, to promote participation and to amplify the voice of the communities that we work with. So keeping that in mind, and also this other part of our history, we work in a very, very collaborative way across the city, across the state, across the country, and also globally. We are part of several networks and campaigns. And so there's a sort of a vertical link between the grassroots communities. And the idea is that their voices and their issues be amplified and visibilized at all levels and to reach policy making levels. And the other thing is horizontal sort of relationship where we relate with other campaigns and other alliances and networks. So capitalizing on all of this, we have a cadre of peer leaders, young women, girls whose capacities have been built, and they actually, exercise sort of collective leadership, identifying the issues and mobilizing resources. And one of the things that we were able to do during the COVID crisis was to link with all right to food campaign, for instance, the right to food campaign, the People's Health Movement, and all of these sort of friends and collaborators whom we have, to be able to provide relief in terms of food, in terms of livelihoods. The girls were making masks and sanitary kits with sanitizers and with other things. And we were able to supply them. The girls were able to sell them and earn some money to help support their families. All of them are in the informal sector, loss of livelihoods, and the girls were able to raise some little bit of money so that, and also were able to mobilize food so that the basic needs could be taken care of. So so this is the way. And also I think this provided an example. We spoke about this, we wrote about this, the girls, we do photo voice, video voice sort of exercises with them, and we were able to disseminate all of this very, very widely and showcase this as an example of local solutions for local problems. So the government should give resources, should give the resources in the hands of communities and allow communities to decide what is the best way of allocating them and using them in a decentralized way. So one size does not fit all. So that's a sort of idea that we want to promote, and local leadership and collaboration, and solidarity, basically promoting solidarity. And so to exemplify these sort of values and really to take them further. the thing is that there are challenges to all of this. I mean, if you're talking in a larger sort of frame, the challenges are that it takes a lot of resources and it takes a lot of time to build capabilities in communities, to foster that spirit of solidarity, and especially within urban communities where there is no sense of community. You know, in the urban areas, people are there, as I said, migrants from different states. And so there's a lot of competition. So, so the way aid comes in, it is very projectivized, you know, short-term projects, and you're supposed to show fantastic results for long-term processes, you know, for what are long-term processes. So this is one huge challenge. The other challenge is the issues of representation and voice. At all times, one has to be conscious whose issues are being represented and taken up. You know, who are even the more inequitous in this whole framework of inequity. So the perspective of intersectionality, the perspective of diversity, getting different voices in, getting different issues represented, all of that is a constant challenge. There's a struggle and competition for resources, for power, for space. Can you hear me?
Yeah, now you're back. Yeah. More or less.
Okay.
Sorry, the sound is very bad.
The was going. So there are challenges that I think it's hello. Yeah. Okay, I think my network is bad, so let me stop speaking, and so that you can make good use of the time. Thank you for this opportunity.
Thanks, you, Renu. We come back to you in a minute to see if the network is better. And thanks for having shared some entry doors and the challenges also that you're facing, that we are facing as a humanitarian community. And on my side, for humanitarian inclusion, I just very fast building on what you said, because we really believe, because we saw on the field that promoting meaningful participation, for example, of diversity, and in this case of person with disability, at all level of the health policy process, for example, is absolutely crucial, and it's the best way to make a process inclusive. So we have a lot of guidelines online, and some of them are very good, with very good tips, but it's not, we cannot use just a checklist of course, at the end of the day, but really to promote meaningful participation is great. And once Sandrine mentioned also the empowerment is also a goal, and then the process and the meaning in the meantime. For example, we have a similar project with persons with psychosocial disabilities and lived experience and mental health condition, really supporting those groups in a multi-year project and multi-country project in order to empower them to take the stage and to advocate for themselves. And this is actually what is happening. So my final statement about that is that our idea is to see social determinants of health through the lens of disability issues, thinking at barriers that a person with disability, with all the diversity included in this concept, could face to have equal access to each one of the social determinants of health, because it, of course, is a human right. I'm just stopping here. I see that the time going very, very fast. So it's impossible for me to wrap up because it was really too rich. So what I suggest is really to do a very, very short round table, 1 minute each with a takeaway, really your final statement or what you learn from each other, and or what you stress once more. Masuma, do you mind to start, please?
Okay, well, I actually just want to lots of lessons learned from all of you, but just emphasize Rena's final words, and that is how incredibly important it is to raise broad-based social development health awareness and form strategic alliances, and basically how do you really mobilize support or drive change, and the importance of telling a story of inequity, a story of deprivation that connects with lived realities and mobilizes people at every level to organize and make claims to rights, equity, and self-determination. And I think that's incredibly important. Thank you.
Thank you very much. Sandrine?
Thank you, David. First, I fully support what you just said, David and Masuma, and just to add that if we take the example of COVID and access to vaccine, I think it reveals our world is driven by decisions that reinforce the power of some groups, rather than decisions that could effectively serve all and decrease inequality, if we speak of intellectual property rights, for instance. And I think our role as NGO is to be in the field, working with people to find solutions that are adapted locally, and also to facilitate the voice of people to be heard at global level. I think for us, it's to be really at both locally and globally, because we have the possibility to do so, and really to make sure the voice of people from the field that are heard, and that in the decision-making process at all level, we could include everybody, for that the policy are built from the people that will benefit from them. So yeah, that's it for my final statement, and waiting for your questions.
Thank you. Renu, if you hear us, please, the floor is yours. We don't hear you. It seems that your micro is off. I don't know if it's a connection problem or yeah. Please try again.
Carry on.
Yeah.
I can't hear, so just carry on. I can't hear anything, so just go on.
Trying on the chat if it will be easier, because we heard you. No, it seems that there are some communication and connection problem. So on my side, I want just to take away the concept that Masuma shared on the importance not only in the research but also for donors and also in our organization to break in the silos and to adopt and operationalize this system thinking, because to address social determinants of health is complex. We show it, and sometimes we are not really ready to think about that because we are too focused on different sectors, and sometimes we need a new sort of epistemology, a new sort of way of thinking or mindset to really put all those elements together and in this way to have a more meaningful and impactful action for vulnerable population. That's what I'm taking from this meeting, among many other things that you highlighted. So thanks for that. So I don't know if Renu could join us with the audio to say something. Let's try.
So thank you very much. The problem is that I haven't been able to hear much of what the others have said. So I can't respond to anything. And so I just feel it's a one-way communication happening. But I think the idea of this panel was very, very valuable in terms of looking at the experience of COVID-19 within a social determinants framework, and also how to respond to it based on that kind of an analysis. I just wish I could have heard everybody, because then I would have been able to relate my experiences with others and, taken away a deeper understanding of how my experience or Sahed's experience actually stands against the broader backdrop of social determinants of health, as well as the COVID issue. So thank you very much.
Thank you, Renu. Thank you, Sandrine. Thank you, Masuma. And thank you for organizer of this meeting, and also for the ICT support. And thanks to all listening. I saw the number there, very interesting. So I hope it will be useful.